So next speaker is Henning Tiemeier. Henning is professor of psychiatric epidemiology at the Erasmus Medical School Center and in Rotterdam, and is adjunct faculty at the Harvard School of Public Health, where he teaches child psychiatric epidemiology. And he received 2 degrees, one on medicine and the other in sociology in Germany. And his research interest is in the etiology of common psychiatric disorders, and he supervised the child psychiatric and cognitive research in Generation R cohort. This cohort in the Erasmus Hospital followed 10,000 children from week 12 of pregnancy. So I think it's quite a gift for us to listen about this cohort and what they are doing in this cohort. So I think it's a privilege to have Henning here. Thank you very much for coming, Henning.
Sit here?
I think, yeah, you could sit here, no? I want also to be here, but...
So you don't need, I hope you can understand my English, otherwise I understand there is some translation. Thank you very much, Jordi, for the very nice introduction. Thank you for being here on a Friday afternoon with beautiful weather in Barcelona. I can think of other things to do, and soon there'll be football. Now, Jordi invited 2 of his colleagues over the years and perhaps friends from Rotterdam, one working on child and one working on the adults. And our goal is to show you how neuropsychology can meet epidemiology, or I could say the other way around. So my talk is the first of the 2. It's modifiable risk factors for neurodevelopmental problems. It is indeed data from the Generation R study, and I call it population neuroscience, where neuropsychology meets epidemiology. So it's a fancy name for something very trivial, if you wish, but it's not. Let me give you what I want to talk about. I'll tell you a bit about the Generation R study, and I've selected just 2 topics, otherwise it becomes this mixed bag. You know, I've tried to focus on 2 things: maternal thyroid deficiency and parenting, how that affects cognitive development. So I'll talk about this study, Generation R. The R stands for Rotterdam. Rotterdam is the second city of the Netherlands, the big port in Europe. But this is a prospective cohort design. It started early in fetal life. We tried to include the women, the pregnant women, when they were 12 weeks pregnant. And we didn't manage the 10,000 we promised our funding agencies, but at some time, nearly 9,000 or 9,778 women participated and their children. And some of the results I'll show is from the subgroup, which we call the focus cohort. And note, Rotterdam and our population participating in this cohort. So these are the ethnic distributions in the participants. It's a multi-urban city. So about half of them, the participants in our study, are Dutch, 10% are other Europeans, and then there is a mixed bag of people from all different backgrounds, and they are mostly guest workers, or they reflect colonial history. And that makes some of our genetic studies extremely complicated, some of our dietary studies also. And that's another story we can talk about. But even for some cognitive tests, it's actually quite challenging in young children. And just, I'll rush you through, in sake of time, through our measures. So one important thing is that we have these ultrasound measures in early pregnancy, because that's what attracted women into the cohort. So Jordi, if you ever think of studying a new cohort, pregnant women can be motivated if they get excellent pictures of their children. You know, the routine healthcare at that time didn't offer any in the Netherlands. Now, I bet in Spain it does, 1 or 2 echoes, I think. But if you say they're longer, they're better, and you can see yourself, they will come and participate. So that worked well. Then we took blood. Perhaps I should just say that we took blood in children and in fathers too, which is quite, you know, an effort in 6-year-old children to get them to take blood. So if you work with children, you may know that that's hard. But taking blood is even harder in that young children, I believe. They're all, no. We had many, many questionnaires. I can't go through the details, but all these arrows show you questionnaires. So if you participate as a woman in Generation R, you'll be overloaded, or you have been overloaded. And so we measure many things, also from the cognitive domain with questionnaire. In particular, we have child behavior questionnaire. You mentioned such data. So those are questionnaires that are filled in by mothers, by fathers, and by teachers on the different aspects of behavior of the children. And we have some cognitive testing by questionnaire. It's not cognitive testing, it's cognitive reporting. You can criticize that later. We have them in our lab, and what you see here, for example, I won't show any results, but that's a very fancy test. It's a child trying to recognize emotion, and it worked. 3-year-old children, you can make them with a touchscreen, see, is this a happy face? And down below, which one of them is happy, like the one above. So that's what we did. And perhaps I'll show you some results, but I have to mention it. We have now started, that's my own line of research interest, started MRI imaging. When they were 6 to 8, we have 1,000 brain images, and just in November, we completed 4,000 brain images of children aged 9 to 10. That is the biggest pre-adolescent imaging data set in the world. So I'll show you some of the first imaging data of 1,000. So that's the overview, and many, many other measures. This is a multidisciplinary cohort of lung, of teeth development, which I can't bother you with. So prenatal exposures. So Jordi talked about some. I'm not sure I've listed his environmental measures that much, the pollutants, which we looked at together with him, but I'll go you through the list. So we've studied family distress, depression of the mother. Most of these are maternal risk factors, smoking and cannabis use. You talked about prenatal smoking in the beginning. Antidepressant use we studied, fatty acids, thyroid deficiency, and that is what I will focus on, and other nutritional deficits. And just for Jordi, because he invited me, I showed him that we also do some new environmental toxins. So I'll have 4 slides I squeezed in on organophosphate, also because they are related to thyroid. Here we go. So hypothesis 1, and that's one example because I spent a lot of time working on thyroid deficiency. Exposure to subclinical thyroid deficiency during early pregnancy is related to child neurodevelopment. That is what we tested. Let me just give you, actually if you listen to his talk to Jordi's, you saw a wonderful slide on synaptogenesis, myelinization, and the prenatal development. So this is much simpler, I'm a very simple epidemiologist. So I just want to tell you the importance of thyroid hormones for brain development. So if you know a bit about thyroid hormones, it is a hormone that obviously our thyroid produces. And if you as an adult have too much, you get a bit hyper, you got sweating. If you have too little, you slow down, you get big. In children, or even in embryos and fetal life, it is much more important in a way because it is a neurodevelopmental hormone. So it doesn't just regulate, thyroid does a lot, but not only our energy metabolism, but it also really makes neurogenesis. That means how neurons develop and that they migrate to the outer layer of the brain. That's in early pregnancy. Later, it does synapse formation and the sort of white lining across the neurons. So that's myelination. So it's very important. The other thing to remember is that the fetus or the embryo does not produce any thyroid hormone himself until week 16, 20. We don't really know. We have to infer that partly from animal work. In early life, certainly not. And at the end of the pregnancy, he produces or she produces her own hormones. So there is a period where he relies on the mother's hormones. And at the same time, it's a very important hormone for the brain development. So the mother needs more than she normally does. So many women that have sort of a good level all of a sudden have too little. And not really too little that they have symptoms, it's subcritical too little. And that's typically in the early pregnancy. So that was what we were interested in. And what is also important, so you can study different parameters. I won't go, this is a psychological audience, so don't you worry that you need to learn them, but there is stimulating hormone and thyroid hormone, this and that, and you can measure different things. So what we did is in 5,000 women, we managed to measure this early pregnancy, the thyroid hormone levels. That is a big set. It was one of the biggest sets a few years ago at that time. And what we were interested in those that have a normal sort of level of hormones, but just too little of the real active thyroid hormone. Just this lowest 5% of the women without symptoms. And you can say 5% is not much, but 5% means that in this room, if you would be pregnant, all of you, that would be quite a few comes together. So it's quite a few children. And this is just to show you how complicated during pregnancy. I don't have a pointer, but I want to point out one thing. This is the blue, shows where we measured it, but it is a time when there is sort of the stimulating hormone goes down, but there is another hormone, which is essentially a pregnancy hormone that stimulates the thyroid. So essentially we think thyroid is so important, the hormones for the child, that pregnancy hormones itself is a thyroid stimulating hormone. It just makes sure that the maternal thyroid is working on full speed. And at that time, there are children that have not got this normal small peak in free T4 they need for their brain. That's the ones we're interested in. So the first data, if you wish, the first neuropsychological data, very simple data when we started this, the first data we had in the children was just language development, just language production, if you wish, expressive language production, and we measured delay. You can just say, which are the children that have the least 10% of expressive language, who know the least words. And then you see, perhaps you should just focus mostly not on the other hormones, but just on these 5% with very low thyroid hormones, that they have a 70% increased chance to have language delay. And what makes this interesting for us, it's a very consistent effect, although those children that are delayed at 18 are not necessarily the same that are delayed at 30 months. Actually, it's not very stable at all, but the effect is stable. So whoever is delayed, the relation with low thyroid hormone was quite consistent. So this was the first paper showing there may be something going on, that if you have during pregnancy low thyroid hormones, your language development is delayed. Okay. And then at that time we didn't have much other data, so we went back to our echo data. This is the ultrasound data, and you can see we can measure many things. This is the head. You can measure the head circumference, for example. You can measure the fetal weight. Because they came 3 times, you can make trajectories very nicely. And what we then said, well, if the language is bad, we think that probably the head is smaller. The head or brain growth must be smaller in those that are exposed to low thyroid. But however, what did we see was quite a surprise. We measured 3 times during pregnancy the head size, and we measured the head size after pregnancy, and we found consistently that those with hypothyroidemia, those with low thyroid hormones, had, if anything, a bigger head. The red line relatively is the head size of those with normal thyroid hormones, and those exposed to low thyroids had bigger. And these are very different measures. The first are from ultrasound, and the others come from our child healthcare centers, where they just took something like that. And we got the same effect, completely independent measures. So it's really not a measurement artifact. It's quite a surprise that there's a few hundred children that have bigger heads if they are exposed to thyroids. Now that's quite confusing. I told you it has this neurodevelopment effect, and then heads get bigger. Now, we didn't publish this well because nobody believed it. And then we thought we should have argued differently, because if your language is impaired and your head development is bigger, what do you think that could indicate? It could actually indicate that these children are at risk of autism, because autism is another neurodevelopmental disorder which is associated with language delay and, of course, repetitive behavior, and you know it all, and bigger head size in infants, where you see that exact same, early infancy is when autistic children have bigger head sizes. So lo and behold, a few years later, we had our autistic data. This is not autism, this is autistic traits, so it's a continuous measure. And what we saw is that both in boys and girls, in the total sample, those in red, the small group in red, have higher levels of autistic traits. Those are, again, the ones that are exposed to thyroid. So you see the story developing over the years. This was published much better, I can tell you that. So it was a very convincing story that we could show that it starts with poor language development, bigger heads, and then it goes to autistic traits. Wow. And then we did something, I should not disclose it, then we thought, if autism, what about the IQ? In this picture, actually, we corrected for IQ and many other things. We looked at the relationship with IQ, and that was very recent, because in the beginning there was nothing. And then another student looked at it again, and what we found here is something different. This is what we call a curvilinear relationship in epidemiology. It means, and I'll take you through, it's not only that low thyroid hormones are bad for the IQ development, but it suggests that also high thyroid levels during pregnancy are bad for your child IQ. It's about 4 IQ points at the beginning, if you have very low. There's also a few IQ points if you have very high. So this is actually not so surprising if you have a hormone that too much is bad and too little is bad, but in a way that in pregnancy it hadn't occurred to us. That's a bit embarrassing, but all of a sudden we found it. But it's not only us that hadn't occurred to us. Just when we published it, the English had a randomized trial in the New England Journal where they supplemented children with mothers with low thyroid levels during pregnancy. They supplemented and then later measured the cognitive development in the child. And interesting, because we talked to these investigators who had a null effect in a trial in the New England Journal, which is quite remarkable that they published it. And why is that so interesting? Because in their study, they gave the women an extra high dose of thyroid levels just to make sure, because they had low, that there would be, no deficiency left. And in hindsight, you may wonder, had they kicked the women from one extreme to the other, and thus from the risk of low thyroid levels to the risk of high thyroid levels, which both result in low IQ. And actually we know that at least 20 women withdrew from the trial because of side effects of high thyroid supplementation levels. So it is quite a realistic possibility. So that made quite an impact. And now comes the imaging. So, we submitted this once and they sort of didn't believe it, this curvilinear effect. And all of a sudden we did the following analysis with imaging. So this is our imaging sequence. This is just a mock scanner on the right. You see a scanner where we practice with the children to, we have they get the terrible sound of the MRI to get used to the MRI, and then they are pushed into the machine. So it's a reasonably big study. 1,000 children participated. In 760, we got acceptable quality. Quite a few children are too scared to go into the MRI. And then, just showing you one of the sequences, this is just the way we measure with a T1. We measure the sizes of different parts of the brain, the volumetrics, if you wish. And what we found, and I'm still with thyroid, is we found exactly a very similar picture. If you overlay the two, you would see again that this is the curvilinear, so it means that low levels are bad, right levels are high. Bad for what? This is the gray matter of the brain. This is the total of your, essentially, cortex, but also other gray matter in the brain. And it shows again that very low levels are not so good, and high levels. Very, very consistent with the IQ data. It's a much smaller group, but still the same pattern. So it does suggest for the first time more strongly that the low levels are bad, but that there may be also an impact. So that was the thyroid story, if you wish. I won't take you through this, which would be the next steps. One of the next steps, perhaps I should just mention, is why do people have low thyroid? I should tell you that it's not the iodium in the Netherlands. The Netherlands is quite a iodium-rich country because it's in salt. So if you ate bread, as a good Dutch person does, then you have enough. We now know that some of our ethnic minorities, which I showed you, don't like to eat bread in the morning. They eat something very different. It could be rice or it could be cake. And then they are more often susceptible to iodium deficiency, but even in them, it's not the biggest factor for thyroid problems, and we did the same analysis excluding all the ethnic minorities. It is not the iodium. We now are interested whether some environmental toxins cause this iodium deficiency, and that's one of the reasons we did the following. We tested exposure to organophosphates during pregnancy. Organophosphates, a few months ago, 2 years ago, I didn't even know what that was. That's sort of pesticides, things used in, or actually, it's not only pesticides, it's things used to make plants grow better, fertilizers, I should say. So organophosphates are used in agriculture. The Dutch is quite an agriculture-intensive country. And one of the things, we had a pilot a few years ago, showed that we had the highest levels in Europe. I've seen now international, I think we're competing with some parts of South America where they are, having banana farms and stuff, and Mexico, I think as well, has extremely high levels. In Europe, the Spanish I've seen, the Canadian data is much lower. So I come from a country which has high iodium, but also high organophosphates. And we just got a grant a while ago to measure organophosphates, which are used in food crops in 702 women during pregnancy. And the Americans insisted on measuring it 3 times during pregnancy in each woman. I wanted, if we have for 2,000 the urine, we could measure it in everybody once. We increased the power. It's an interesting epidemiological debate what to do. But anyway, they have the money, so they rule, and they said, we want to have repeated measures. And then, I can't hardly pronounce these things, but it's alkyl or dealkyl phosphates and the metabolites in urine. There's different groups. I'll just talk you through one of them. So what we then have them 3 times in pregnancy, and then you get epidemiological designs. Do you take a mean? Do you take each analysis? And I'll just show you a multi-level analysis that I conducted the way I do it, which is a bit complicated because you twist with outcome and determinant, but it shows something to us very clear and very highly significant. So this is a curve that across pregnancy we had these multiple measures, and what you can then see is, let's take, there is a relation between, that's why it's sort of a bit curved, the IQ and the organophosphates. The easiest way to understand that, if you take the 90th percentile, which is sort of the lower curve, you see that those children born to mothers with the highest levels of organophosphates. Now let me do it the other way around. It's a bit complicated. So you have 3 groups: the average, the children with the highest IQ, and the children with the more lower IQ. And you see that it's the other way around. The 10th percentile of IQ is the lowest IQ. So sorry, that's the lowest IQ is up, and those with the lowest IQ on average have the highest pesticides, and those with low pesticides have the 90th percentile of IQ, which is the highest level. And you see the difference at the 2 ends of pregnancy. So because I messed it up, I'll try it again. So you can, it's a continuum, but you can of course make groups. And then you look at the groups which represent one distribution of IQ. So if you wish, we take those with the high IQ, and they, on average, have low levels of pesticides in the beginning, at the end of pregnancy. What that means, it means that there's a particular effect of organophosphates early in pregnancy and at the end of pregnancy. It's related to IQ, and it's quite, if you have 150, if the concentration in nanomoles per gram is 150 higher, then you can see that there is a bit of a shift of IQ. It's complicated to depict repeated measures, multi-level analysis. Another way would be to show you the association. I can show you if you do the simple, I can tell you that if you do the simple analysis of just the end pregnancy levels, you would see a significant dose effect between organophosphates and IQ at age 60. So there is an association. So I'll practice my talk, it's very decent data. And the next question I had is where this is, and that's quite interesting. The main source of organophosphates in the Netherlands is fruit. We can't track that. We have no data where the fruit comes from. We try to look at it by season, but there seems to be no association between that. But it is in fruit. Why is that so interesting? Because it's the first thing it is. If you even click on Wikipedia, it says it is used in fruit crop. So it is no artifact. That's the first thing. It actually explains this. The other thing which makes this so interesting is that if you have fruit as such, it's related to higher IQ. You can correct most of that with SES and other behavioral lifestyles. It's not a true effect. But in this instance, it means it was negative confounding. I don't want to take you through that, but it essentially means that the chance that there's residual confounding here is quite low because it goes the other way around than socioeconomic status and income emissions. This is an effect you see in the women which have a healthy lifestyle, which do sport, which eat fruit, and then you can see the effect if you adjust. If anything, the effect gets stronger, which is not what I normally see. So if I put smoking, it gets even stronger, so I can get stronger and stronger with adjustment. And it is significant indeed without much adjustment. So it is a quite remarkable thing And again, this doesn't tell you much about the effect size because it was just a 10th percentile. So it is not a big effect size because it's a huge group. Let me tell you that. It's not that if you eat fruit that your child becomes a few IQ points smaller. It's 1 or 2, which I think is a big effect. So you said 4 IQ points are not a big effect. I'm happy to disagree. We're both disagreeing. 4 IQ points in your child, 5 IQ points make the difference between average school and better school. And that's not such a big difference. We're not 25 points slimmer than the carpenter. Don't you think that we have that degree? No way. Small differences matter in IQ. Okay, so maternal hypersacuration is a risk factor for different neurodevelopmental problems. I told you about this inverted U-shape, so it's not only in one direction, it can be both higher and lower levels, and that prenatal risk factors, I don't know if that became very clear, but I think they have very low effect. So we have one of the students here in the room came to our lab, and we studied things after, let's say in pre-adolescence or in preschool years, they have very pinpointed effects. But these prenatal effects of thyroid or gamma phosphates are very low for the brain. I think there's time, or should I stop? I'm not sure how it is the time, because you went over time. Should I do one more topic or stop? I was going to show you the video of how we measure parenting. I'll skip this, that's for sure. I won't spend 9 minutes. I'll show you just these two results. So parenting and neurodevelopment. So we're switching to a completely new topic. I have argued, or still argue, that during pregnancy it's very much biological, intrauterine effects. We saw all this. Once the child is born, what matters for neurodevelopment is not it's breastfeeding, but otherwise it's much parenting. It's the interaction with the mother. So we're thinking of a child between 1 year or half a year and 5 years. Before it goes to school and has friends, then there's a new social environment. Otherwise it's the family. Because the family has a social adversity, if it's very poor, but otherwise it's family adversity, which can be harsh parenting or insensitive parents. Harsh parenting is just, if you follow me in English, means that you pinch your child, you beat your child, you shout at your child. That's a very, you can say that's not bad. If you're exposed to that for many years, that's quite a dramatic thing. So what we show here is we measure that, and we measure that in films partly. So we observe these children, and it's quite interesting how poor that was the film. Some mothers parent, they sort of, you say, let your child do this task, and after 2 minutes the mother takes over because she thinks that the child is so stupid. So these are, mothers which are not so sensitive. Now, if you have these mothers, you can show that their child develops less well cognitively. What we measured was working memory and inhibition, and I think Dory explained those quite well. It's the same measures, actually. It's lab measures and young children. And then we showed the father, there's a different pattern. It seems to be less of the father as it is in harsh parenting measures more than the sensitivity. And then, I'll skip this one. There's many studies of extreme institutionalization, extreme neglect of children. This is a famous study in Romania where they show how that impacts massively on the brain development of the child. This is a group of Nathan Fox and Chuck Nelson who studied these children as they grew up in the West or even Romania and showed how dramatically their brains developed. We did the same. I showed you before how we measured the morphology of the brain. This is a study of 200 kids, which is quite a big imaging study. And all these children, we have not only measured we have the ultrasound of the size and some aspects of the brain, but when we put them under their eye many years later, and we have observed the parental-child interaction. So these are not questionnaire data. This is repeatedly in the mother 3 times the father once observed. So even the fathers, they didn't want to come to our labs, so we went to their homes. We went with our video cameras to their homes. We had them do these interactions and film them. And what it shows, the father effects are not significant, but we show that there is more grey matter volume if the parents are more sensitive at age 6 to 8 years. So this is not so much the hippocampus, which is probably influenced by earlier things, but it is the overall grey matter development. And this is a slide showing you where it is. It is sort of the middle frontal lobe mostly, both on the left and the right side, where inherited less sensitive by these models. And I was going to give you that example for the sake of time. I'll skip that. And perhaps I'll show you one last result and then I'll finish off. This is the next study what we're doing. We're using another image which we call, or which is called resting state. So we have in most of the children, in the pilot of 1,000, we had resting state, and we wanted to relate that to very similar sensitivity measures. And what I'll show you is that data in the slide. It's very hard, so let me just explain that to you. We have in the brain different connectivities, and with resting state, you can try to map them. Essentially what it does, it takes the blood flow as a measure to correlate between different brain regions. You must have heard of that. Resting state MRI is quite fancy, and you can find different networks which correlate essentially with their blood flow. And this correlation is a measure of functional connectivity. And then there are different regions where the connectivity is particularly interesting if you measure sensitivity, and one of them would be the prefrontal amygdala. Amygdala is emotion regulation, and the prefrontal cortex is heavily regulated in the amygdala. So we measured it, and I can just make it short, there was no effect. So I said, see, that's negative, this was too fancy, we can't relate functional connectivity to parenting. And then the student tested it further and said, well, really, there is only an association if you interact with age. Essentially, that means that different in children who are parented less sensitively, the connectivity, and that was a surprise, develops faster in earlier age. So I said, go home, I can't believe any of that, these interactions with age, what are these? They are a nuisance. So that's hard to imagine. Why should children, where the mother is less sensitive, mature early of the midterm? I couldn't think of anything. So the student was a bit disappointed because she said, you told me to look at interaction with age. I'd already forgotten, to be honest. And that was because these connectivities are highly dependent. They develop with age. So she said, that's why I keep told, and still. Only then did she come back. And this is one example. There's a whole developmental literature which I was unaware of, that if you are deprived, what happens is that your amygdala connectivities do, and that has been shown in institutionalized children, they develop quicker. And actually, thinking about it, we know much more literature because we know other examples, even as epidemiologists, that if you are exposed to social adversity, even your menarche will develop earlier. We know that from animals, we know that from humans. We know that very well, that social deprivation makes us age faster. If you interpret this connectivity as an aging of the brain, then it makes complete sense. So this is unpublished, very new data from our group, that even if we observe the most insensitive parents, we may see that effect in the general population. And that's it really, and I'll stop. This was an example, these were two examples of thyroid and parenting. Just if I summarize it, the thyroid is important for the general brain development, and the parenting, I think we may underestimate as neuropsychologists, or epidemiology, it does influence brain development, I argue. No surprise that one of the slides I had made on notice was of one of these Time magazines. We all know that, the tiger mums are one of the big phenomena in America. If you even talk to America, they always say, don't believe any of that parenting shit. And then at the same time, I tell them, why is it that the Chinese are doing so well? Is one of the arguments is they are parenting quite differently. Not that I'm talking about tiger mum parenting, but I'm showing that there's much, I think, not evidence, but there's much to think about why parenting could influence the way our brains develop. So here we go. Neurodevelopment is strongly related to family environment. I argue multiple co-occurring early environment exposures influence. Actually, they co-occur, these different risk factors, smoking and these exposures, which makes it so complicated and confounding. Influence neurodevelopment. Each, I think, was a small effect. The strongest predictor of any childhood, don't forget, is the same health record in the parent. This is for a disclaimer. How can we ever adjust for that? And I would like to talk another time how we can intertwine, tie this together with changes. I think I should stop there. Thank you for your attention. Also,